presentation, and they are on the line here with us, on the Zoom call with us. Jonathan, are you going to kick that portion off and introduce your team?
Gosh, yes, I will do that.
Perfect. Then the show is yours, Jonathan. Thank you.
All right, fantastic.
Well, hang on a minute, just a second. Star, who is with our IT, some of you may not be familiar with how to use Zoom, and she wanted to give just a couple of brief comments on what that process will be like in case anybody's got any questions.
Hi there. So my name is Star Lucas. I'm your Zoom moderator for this call. We've muted everyone upon entry. There is a raise hand feature that you can select when you hover over your name. If you have a question, but we ask that you hold questions until the end of the call, please. Hold on one moment. I'm getting some folks I got to mute yet. Hi there. So my name is Star Lucas. I'm your Zoom moderator for this call. We've muted everyone upon entry. There is a raise hand feature that you can. There we go. Can you guys hear me?
Yes.
Thank you. Again, this is Star Lucas. We got some background noise there, so I had to step away for a second, mute some lines. So we will mute all the lines if you could hold your questions until the end. And there is a raised hand feature at that time when we open up for questions. We can go down the line one by one and address any questions you might have at that time, but we'll let you know when we're ready for that piece.
All right, Jonathan, go ahead. Thanks.
All right. Thanks, Josh. Thanks, Star. Again, my name is Jonathan Shrianfi. I'm a principal at Plant Moran in the Plant Moran Group Benefit Advisors practice. We've been working with the county for seemingly coming up on just about a year now with respect to helping to put together some benefit options for the retiree population of the county. And today what we're going to do is go over the materials and the what we will be rolling out for 2021. Okay, so just a little bit of laying some groundwork first here in terms of how we're going to do this. So right now there are two distinct types of retirees that are participating in this meeting today. The first are retirees that have not yet hit the Medicare age of 65. And then there are retirees or covered spouses of retirees that are Medicare eligible. So that would be age 65 or older. And in some cases, there's a disability involved. Some people can be on Medicare that way. So the distinction that we're going to make is that there are pre-Medicare retirees and Medicare retirees. And we're going to first go through the materials associated with the pre-Medicare retirees. So I'm going to go ahead and share my screen here. And I'll ask if everybody can see that. 1 second. Josh or Star, can you see the screen at this point?
No, we can't see it. Do you have the share screen option along the bottom, the little green box with the arrow?
There we go.
There we go, Jonathan.
There you go.
All right, fantastic. All right. So again, what we're going to be doing first here is we're going to be reviewing the materials and the benefits that will be applied or applicable to pre-Medicare retirees. So if you are on Medicare right now, what we're about to go over here first does not apply to you. We'll get to your section here in a bit. So just as a means of to go over kind of the contents of these materials, we're going to just go over really quickly kind of the current state. We're going to give you a summary of what's changing and what's going to be available for 2021. We're going to talk about plan administration and the networks and the designs of the benefits. We're also going to go over some of the additional benefits that are going to be available to you as part of this rollout. And then we can also talk a little bit about some details with respect to the plan designs, but we're going to leave that to the very end. So with respect to pre-Medicare or pre-65 retirees right now, we've really got a number of different current state benefits. The first is that there are some retirees that have a Health Alliance plan, and that is a fully insured medical benefit that the county currently provides to some retirees. There is a self-insured medical benefit through Blue Cross Blue Shield of Michigan. And then lastly, all of you right now are getting your prescriptions through Express Scripts. So most of you right now are carrying around a medical card and carrying around a prescription card. And you'll see one of the changes that we're going to talk about in a bit is that we're going to consolidate that going forward. So effective January 1st, 2021, all pre-65 or pre-Medicare retirees are going to shift from your existing Health Alliance plan or Blue Cross Blue Shield of Michigan plan to a plan administered by Meritain. Those plans, and there are different kind of flavors or different designs with Meritain. Each of those plans, though, is going to use.
I'll be with you soon. You need Danielle again?
Each of those plans is going to use Aetna's national provider network. That means that you will have access to providers coast to coast, regardless of your residence or whether you're traveling. So if you do travel for the winters, or if you have multiple residences, these plans are going to travel with you, okay, regardless of where you're at, and it's a nationwide network. Also, you're going to see that there are minimal plan design changes. So while there are plan design changes from what you have right now, we have attempted to keep those as minimal as possible. And then lastly, one thing that we need to make sure you understand is that your prescription drug benefits, so that those are currently provided through Express Scripts. Those prescription drug benefits will remain with Express Scripts as of January 1, 2021. That said, there will be some changes to the prescription drug benefits, namely some small changes in the prescription drug copays, but also formularies. That's the list of medications that are covered. Formularies typically update every 6 months. And that usually happens on July 1st and January 1st of every year. Those formulary changes will be happening January 1st. We're also going to be making some changes to how specialty medications are filled. Namely that we're going to be running specialty medications through a new program that will generate some savings for both you and the county, and that certain specialty medications are going to be covered at no copay, meaning those specialty medications will be provided to you at no cost. And this actually does, oddly enough, generate some savings for the county as well. So you will see that. Now, mind you, not everybody takes a specialty medication. Specialty medications are frankly pretty rare. Usually only impacts about 1% to 2% of a population of people. So it's not, this change isn't going to impact everybody, but those that are impacted will see some advantages in terms of getting their specialty medications filled. The other thing that you're going to see that for pre-Medicare retirees is that we are going to be rolling out a new advocacy service called Quantum Health. And you might see it referred to as MyQ Health. But Quantum Health is going to provide advocacy and customer support, medical management, care coordination. Generally, Quantum Health is going to be your one-stop shop for any types of services or help that you need associated with your benefits. So if you need help scheduling an appointment, or if you need to ask a question about whether a service is or treatment is appropriate, if you need a second opinion or think you need a second opinion on something, they're your go-to for support like that. And they are going to help you navigate the healthcare system. Also, it mentioned earlier that your prescription drugs are going to be integrated onto a single ID card. So you will be getting a Meritain card, but on that Meritain card will also be all of your Express Scripts information. So you won't need to carry around 2 ID cards anymore. Also, you will be getting access to a virtual primary care program through a company called 98.6. This is going to be a telemedicine service that you can access at no cost. If you have a question or you think you might have something like a sinus infection or something like that where you don't really want to wait to get in to see your doc or don't want to go to urgent care or the ER, this is a service that you can access telemedicine or virtual consults through your phone. We're also going to be rolling out a service called Livongo. Livongo is for those on the phone that might be managing diabetes. We'll talk a little bit more in detail about that, but it's a specialized service to help you control your diabetes and also get all of your testing supplies. And then last but not least, we have a service that we'll be rolling out called the KISX card or KISS card. And this is a service where if you have a schedule that needs to be, or if you have a surgery that needs to be scheduled, you can actually work with the folks from KISS to schedule that surgery. And if you work through this program, you get all services related to the surgery, you get at no cost to you. So no out-of-pocket, no deductible, no co-pays, no co-insurance, okay? Now, again, that is for schedulable surgeries. It's not for emergencies or anything like that, but it is an added benefit that will be rolling out effective January 1st. So that is a quick summary of kind of the key changes for January 1st, and we're going to get into a little bit more detail now. So for January 1, 2021, like we mentioned, all benefit plans are going to be through Meritain. So there will be no more plans through Health Alliance Plan or Blue Cross Blue Shield of Michigan. Okay. Each of the plans with Meritain will have access to a national network through Aetna. So most of you will be seeing and using Aetna's Choice POS2, and it's an open access network to replace the Blue Cross and HAT PPOs that you might be accustomed to right now. This network includes, for those of you still in Michigan, that network is going to include every hospital in the state and about 98% overlap on doctors. As it relates to Blue Cross Blue Shield of Michigan. For some of you that have the same as active language in the collective bargaining agreements and can choose an HMO, you will have an option through what's called the Aetna Premier Care Network. That is a network that is more narrow in Michigan and specifically in Genesee County. It's centered around McLaren Flint. But that plan and that network is only available to those retirees that have the same as active language in your collective bargaining agreements. All other retirees that are pre-Medicare will have the broader Choice POS2 network. Okay. In the event that you want to search for providers, whether it be at a primary or secondary residence, you can do so on Aetna's website. If you go to www.aetna.com, there is a search feature where it says find a doctor. Where it asks you to select a plan, you're going to say a plan from an employer, and then you're just going to continue as a guest. And you can do a search on the website for providers, and that's going to be by geography. So in terms of plan designs, we've designed 4 plans most of you will be going into the one of the first 3 plans, but plans have been designed so that each retiree is going to be mapped into a plan with that limits the design change to about a 1 to 3% actuarial value difference versus what you have right now. And just so you know, the plan that you're going to be mapped to is dependent on the plan that you're enrolled in right now. We'll talk a little bit about that in a bit. Of the 4 Meritain plans that you might be mapped to, they all have one of 2 levels of prescription drug copays. One level is going to have $2 generics, $5 brands. And then the other level of prescription drug copays is going to be $5 generics, $20 preferred brands, and $40 non-preferred brands. So some of you may say, well, that's very similar to what I have right now. Again, the intent here was to try and keep things as close as we could to current. You may see some minor changes, but the idea was to keep the plan design changes to minimal. And we'll get into some of the details around the other aspects of the plan design here later. So this is very important. When we talked at the beginning, we mentioned that there's 2 types of retirees, pre-Medicare retirees and Medicare retirees. Now, some of you may say, well, I'm the retiree and I'm Medicare eligible, but my spouse is not Medicare eligible yet. Okay. These are what are called split contracts. It's when one spouse is Medicare and the other is not. In these situations, what you're going to find is that the pre-Medicare spouse is going to get the pre-Medicare benefits and the Medicare eligible spouse will get the Medicare benefits. So technically you will have 2 different sets of benefits if you have a situation where you and your spouse aren't the same with respect to your Medicare eligibility. All right, so the next thing we're going to do is we're going to focus a little bit more on some of the added benefits. We call these point solutions. And the reason we call them point solutions is because they're really meant to address one particular need within a healthcare plan. And so over the next number of pages, we're going to talk a little bit more about what those point solutions are and how they work. So the first one, and we mentioned it earlier, is Quantum, or MyQ Health is how you'll see it on your ID cards. But Quantum is a company that provides concierge member advocacy. And what the folks from Quantum will do is they will help you make certain that you're receiving the appropriate care. They will help you navigate what is oftentimes an extremely complex healthcare system. They will help you identify options that are available to you. So we're going through a lot of information right now. Okay. I think most of us, when we hear information for the first time, we retain something like 20% of it. If there's one thing that you want to retain in this presentation, it is that Quantum is going to be your point of contact. If you don't remember something that we talked about, or you vaguely remember it, and you're like, hey, I think I might be able to take advantage of this thing that they were talking about at that retiree town hall, call Quantum. If you don't remember what your benefit levels are, call Quantum. If you have a question about how to use one of your benefits, call Quantum. They're your first point of contact with anything related to your healthcare plan. Okay. They will go so far as helping you to schedule appointments. They will remind you if there is an opportunity for you to take advantage of one of these new point solutions or benefits. And they will also engage with clinicians. So they have clinicians at Quantum that can help you deal with talking with your medical providers. If you're like me and you get kind of shy if you're talking to a doctor because you don't feel like you're educated enough to have that conversation with your doctor. You're not as familiar with all the medical terminology and stuff like that. I always struggle with that in talking with my doctors. So they have clinicians that can help have those conversations on your behalf. And then they also coordinate everything. So if you're dealing with a medical condition and you've got a lot of different healthcare needs, they can help you keep everything coordinated so that the therapies that you're receiving are appropriate. So this next page here is just a quick list of different things that Quantum or MyQ Health can help with. They can answer, they can do anything from the basics like answering claims questions, or if you have a billing issue, like if you get a bill from a provider and you're like, I don't think I should have to pay this, or this isn't consistent with what my benefit summary says. You can give them a call and they'll help you resolve those issues. They can help you create health improvement plans. So if you're working with, if you want to work with one of their nurses to create a health improvement plan, they can do that with you. They're also going to help with pre-certification services. So like these are some of the behind the scenes things that you may not always know are going on with a healthcare plan, but they're going to do pre-certifications with the docs. It'll be really interesting. So things like outpatient surgeries, you may not know this right now, but every time somebody goes in for an outpatient surgery, the doctor's office or the surgeon's office or the surgery center is going to contact the insurance to make sure that you're in fact covered by the insurance and that they're going to get paid for performing that surgery. What Quantum will do is when that request comes in from your doctor, they're going to make sure they're going to look up and say, okay, this covered member on the county's plan just had a surgeon call to confirm a knee surgery. The folks at Quantum are going to take a look and say, wow, this knee surgery is going to be performed by Dr. X, and Dr. X has very poor outcome measures related to knee replacement surgeries. So you might get a phone call from Quantum saying, hey, we noticed that you've got a knee surgery scheduled. We wanted you to know that the provider or the surgeon that you're using for this knee surgery has high complication rates and high readmission rates related to these types of surgeries. Would you like us to work with you to find a surgeon with better quality metrics on knee surgeries? So they're going to actually be looking out for you to try and make sure you're receiving the care at the best possible place based on the types of procedures that you need. So moving on, we talked a little bit about KISX or the KISS card. So you'll be receiving that card in the mail. But really what this program is for schedulable procedures. It's not for emergencies. It's for those procedures like a knee replacement, a hip surgery, complex imaging like MRIs or CAT scans, things that you have to schedule. In the event that you want to work, and this is a voluntary program, you don't have to use it. Obviously, the benefit of it is if you do use it, you don't have to satisfy a deductible or you don't have to pay a copay for any of the services. But the folks from KISS will work with you to find a provider that it can provide the service that you need, whether it's a surgery or an MRI. And from there, you will receive a certificate and you'll use that certificate at the provider locations, and it kind of replaces your ID card. But when you're using that program to receive those services, again, you receive those services at no cost. And the truth is, again, we're not expecting you to remember, that this exists and when to use it. The idea is that, if you want to take advantage of it, or if you think it's something that you can use, we ask you to reach out to Quantum and ask the question. Hey, can I use this KISS program? I need to have a knee surgery. The other thing is that the folks from Quantum might reach out to you and remind you of this, in the event that they receive a pre-certification request for a procedure that could run through the KISS program. And again, it's completely voluntary. If you do not want to use it and you're perfectly happy, running through the healthcare system like you normally do, it's completely your prerogative. But we felt that this would be a program that people would appreciate simply because it eliminates all the out-of-pocket costs associated with receiving some of those procedures. Now, the KISS program is different in that, while they do have an existing network of doctors and surgery locations and imaging centers, when you use the KISS program, and if there is a procedure that you need and the locations that are available aren't convenient, they may work to try and find a more geographically convenient location for you. But sometimes these are negotiated on a one-off basis. So it's not like normal where you'd go onto a website or you'd call and say, hey, who's in your network? The way that you would work through this program is you'd say, hey, I need a knee surgery and I'm in zip code 1111. And they're going to work with you to find a provider, a high quality provider in your area that is acceptable with respect to how far you have to drive to get there. So again, it's not necessarily something that you can just say, hey, where is the network and which doctors are on the network right now. And again, the other thing is this program is not meant to be a PPO network. It's not meant to generate a network with doctors on every corner. This is a very specific program for specific procedures. And if you want to take advantage of it, again, my recommendation is to call Quantum and engage with them and say, hey, I'm interested in this program for this type of procedure. Does it work? All right, so the next solution is 98.6. And 98.6 is a telemedicine or text-based virtual primary care program. It's a program that you're going to access either on an app if you have a smartphone or through the web. And the idea is that the program is initiated through text messaging. So you can actually initiate a consult with a doctor via text messaging. And the idea there is that the initial part of that consult is going to be an intake process. So there is the text messaging that you're going to be doing at the beginning of the consult is really just the generic intake that a doctor's office might do prior to the doctor actually walking into the office to see you. Again, these consults are provided to you at no cost. So if you've got poison ivy, if you have a sinus infection, if you're not quite sure if you should go to their urgent care or if it's something that can wait until the morning until your doctor's office is open, that type of thing, you can reach out and have a consult directly with the physician and it will not cost you anything to do so. The other thing is that the docs that you're going to consult with through this program can write prescriptions. I've used this program before. I usually get sinus infections pretty much like clockwork in the fall when my fall allergies kick in. And so I had a consult once. They wrote me a script for an antibiotic and I went in and picked it up. The whole process from initiating the consult with 98.6 to having my script in hand was 90 minutes. So I had the consult, the doc called in my script, the pharmacy had my script ready from start to finish was 90 minutes. The other thing to note about 98.6 is that the doctors that you're going to be consulting with are employed by 98.6. So this isn't just some program where you're being connected with, some random doctor who knows where. All of the doctors that you're going to be consulting with are employed by 98.6. They go through rigorous testing. They're very familiar with the platform. And they're typically credentialed in, if not all 50 states, a high majority of states. The last thing I point out about 98.6 is that the service really is meant to complement traditional in-office care. It's not meant to replace it. That said, the idea here is that in the situations where you don't really need to go into the urgent care or go see your doctor physically, this is a great solution, again, that will save you your co-pays and some cash out of your own pocket, and it also saves the county some money too. So this next page is just a quick run through of kind of how this works. So you'd initiate a consult. Again, let's assume that you're using a smartphone. You're going to download the app. You're going to initiate the consult, and the app is going to ask you, what you need help with today. You're going to go back and forth with the service, and then a doctor's going to come on to that and join that text message stream. In the event that that consult can be completed exclusively through text messaging, it will be. If for some reason they need to initiate a phone call or a video chat, they can do that as well. And then at the end, you're going to receive a personalized care plan that's going to be housed in the app or on your account. So let's say that you got a care plan, it includes a prescription, but part of that care plan was to follow up with your primary care doctor. You can actually take that care plan directly from the app or from the website and print it out or save it and send it to your primary care doc so that they can see what was provided to you, so they can continue your treatment. The next benefit is Livongo. Livongo, some of you may be familiar with this right now, but is a diabetes management program. For those of you that are working to manage diabetes and have been diagnosed, this program it's voluntary. Again, you don't have to use it, but if you would like to, you can enroll in this program, and doing so results in you receiving a smart glucose meter along with all of your testing supplies at no cost to you. And the way this program works is that the hope is that by providing you with the testing supplies at no cost and the smart meter, that you'll follow through with your testing and such, and be good about that. And the idea is the smart glucose meter, in the event that you were to test out of your range, out of your glucose range, that smart meter will initiate an outreach from a clinician that will then immediately help you work to get your glucose back into an acceptable range. So they may tell you, I need you to go get a glass of orange juice, or but they're going to work directly with you immediately upon testing out of your range to help you get your glucose back in range. The other thing is, if it happens to be an emergency situation and you're non-responsive, the folks from Livongo are going to reach out to an emergency contact on your behalf to let a family member know that you might be in need of assistance. So again, this program is really meant to help diabetics better manage their condition and hopefully get additional help when it's necessary. So just this next page is just a quick look at how this works and the connected technology associated with the smart glucose meter and the testing. And really, I think that the benefit of this is really that last point, which is the human touch. Having somebody having a clinician that's going to immediately reach out if you're testing out of range to help you work to get your glucose back in range so that you don't have a more catastrophic health event to deal with. So with that, we're gonna run through some plan designs really quick. So there's really four, like we mentioned before, 4 different plan designs. And as you can imagine, plan designs are fairly complex, but usually there's only a handful of things that people are really focused on. That's going to be things like deductibles and out-of-pocket maximums and things like that. So again, you will be mapped to one of these plans depending on which plan you're in currently. So this first plan it has a deductible of $100 per person. It has a $200 family max. So what that means is that each family member is going to have a $100 deductible. And so each family member will only be responsible for $100 of the deductible. And the most a family unit will pay is $200. The co-insurance is 10%. So you can see this 10% here for some of these different services. You will pay a 10% co-insurance with a max co-insurance of $750 per person or $1,500 per family. So again, each family member will only be responsible for $750 of that co-insurance maximum. And then the annual out-of-pocket is $6,350 per person or $12,700 per family. But I want to be very, very clear with you on this. This out-of-pocket maximum will likely never apply. Okay? And the reason is because your co-insurance is capped at $750 per person or $1,500 for a family. So if you looked, let's just use the single person as an example, and we say the out-of-pocket max is $6,350. The first 100 of that is going to be your deductible, and the next $750 of that would be your co-insurance. So that's $850. The rest of that $6,350 would have to be satisfied via co-payments. So in $20 increments, $2 increments on prescription drugs, $5, etc. It's very, very, very unlikely that you're ever going to have enough co-pays to hit $6,350 of out-of-pocket costs. Okay? So maybe the better way to put this is, let's say that you had a catastrophic medical condition that required you to go into the hospital and you were there for 3 weeks. Okay? The most that you're going to pay for that event, that inpatient admission, is $850. The $100 for the deductible, assuming that you haven't met it or satisfied it for the year, and then $750 for your co-insurance. So that's why we're saying that it's very unlikely. We need these out-of-pocket maximums in here for these plans to be compliant with federal law, but it's extremely unlikely that you're ever going to hit these out-of-pocket maximums. So the next plan, you'll see that these two plans right here, Retiree Plan A and Retiree Plan B, they're effectively the same plan on the medical side. The only difference is the prescription drugs. So if you're in a plan right now that has higher prescription drug copays, you're likely going to be going and being mapped over to the plan with higher prescription drug copays. But again, the actual out-of-pocket costs associated with the medical plan are the same. And then the last two plans, these are going to be the plans that are more consistent with the current active plans. So again, if you've got language that ties your retiree benefits to the active plan, this is going to look very familiar. So the first plan has a $250 deductible, a co-insurance max of $750. And in this plan, you actually have different out-of-pocket maximums for medical and prescription drug. And again, this is because it mimics the active plan. But your copays are going to be $20 for office visits, and then your prescription drugs are $5, $20, or $40. And then the last plan is what we're going to call the high performance PPO. This is meant to be the HMO replacement. So if you are given the option to elect an HMO and you want an HMO style plan, this is what it would look like. You'll see that the plan design features are fairly similar, with the exception being that the primary care and specialty office visits are lower, as well as the ER. But in terms of the prescription drugs, the co-pays are the same to the other active style plan. So those are the 4 plans. There, you know, prior to these changes, there were a lot more different versions of the medical plans, depending on your collective bargaining agreement, et cetera. Everybody will be going into one of these 4 plans as of January 1st. So with that, I am going to transition quickly over to the Medicare portion, and then after that, we will stop and answer all questions. Just give me 1 minute here to change.
We can see it.
All right, so switching gears here. So we just talked about the pre-Medicare retirees. Now we're going to talk about those of you that are currently on Medicare or will be on Medicare. This section of the presentation is for you. So once again, if you're currently Medicare primary or Medicare eligible, you're likely in one of a couple different plans that are offered by the county currently, possibly a HAP plan. There's also a couple handful of people that currently have a Medicare Advantage plan with HAP, which is an HMO plan, an HMO Medicare Advantage plan. There's also some of you that are on the self-insured medical plan with Blue Cross Blue Shield of Michigan. And then similarly, if you are Medicare primary, you are getting your prescription drugs through Express Scripts or Benistar through what's called an EGWIP or an employer group waiver plan. And that is your Medicare Part D. So you're getting your prescription drugs or your Medicare Part D through the Express Scripts and Benistar relationship. So effective January 1, 2021, if you are a Medicare primary, Medicare eligible retiree, your coverage will shift from what you have right now, whether that be HAP or Blue Cross, and you are going to be moved into an Aetna Medicare Advantage plan. The Aetna Medicare Advantage plans, there's 2 different versions of them, which we'll show you in a bit. These plans have a passive network. What that means is that your benefits are the same, regardless of whether you're in network or out of network. The only limitation that you have is that the providers that you're seeking care from need to participate with Medicare. If the provider doesn't participate with Medicare, they're unlikely to accept your Aetna Medicare Advantage plan. If they do participate with Medicare, then it's very likely that you will not have problems dealing with that provider as it relates to your Medicare Advantage plan. Just like the pre-Medicare folks, we try to keep the plan design changes minimal. And just like the pre-Medicare folks, your current prescription drug relationship through Express Scripts or Benistar is staying the same. And just like the pre-Medicare folks, you're going to see some changes, periodic changes to the formulary, which would take effect January 1st. But again, that's a very standard thing that happens twice a year. And if you've got questions about that, why does that happen? Think about it this way. The prescription drug world is changing all the time. So sometimes they introduce new medications. You want to make sure that somebody's looking at those medications, and if they're appropriate to be dispensed and they're being approved, you want those added to your benefit plan. Likewise, if there are new generics and things like that, you want to make sure that you're getting access to those medications. So if you want to look up a hospital or physician with Aetna for the Aetna Medicare Advantage plan, you would go to aetnamedicare.com, and you can use the find a doctor or prescription, and then perform a search as a guest. Again, this shouldn't be that necessary because of the structure of the plan and because this is a Medicare-based plan and it's an open access passive plan. Most providers are going across the country are going to accept this plan. Again, because it's a Medicare-based plan. So again, we made the plan designs and designed them in such a way that we limited the impact of the plan design changes from what you have currently to where you're going to be about 1 to 3% difference. And just like the pre-Medicare folks, we are going to map you into one of 2 Medicare Advantage plans with Aetna. And that mapping is going to be based on what benefits you have currently. So you're going to map to one of these designs that most closely matches what you have right now. We mentioned it before, and I'll probably mention it 5, 6 more times. This is a passive PPO plan. That means you don't have to go searching out, providers like you would normally have to if it was an HMO or something like that. Most providers across the country are going to take this plan. We work with a number of different employers that offer Aetna Medicare Advantage plans, and we do not hear issues about people being able to access providers. We just don't hear it because so many of the providers across the country participate with Medicare. You'll also see that the Aetna Medicare Advantage plans, they're going to be matched with one of 2 prescription drug copay levels. So you're either going to have a plan that has prescription drugs that have copays of $2 for generics and $5 for any type of brand, or you're going to have a plan that has $5 generics, $20 preferred brands, and then $40 non-preferred brands. And we'll get to the summary at the end like we did with the pre-Medicare folks. And we'll reiterate it one more time. If you're in a situation with a split contract and you are the Medicare participant in the family, you will be receiving a Medicare Advantage plan through Aetna. And if your spouse is pre-Medicare, they will be receiving the benefits that we spoke about in the first part of this presentation. Okay. So the 2 plan designs. What you're going to see here is that we've got the 2 different plans laid out kind of side by side with the different aspects of what's covered. Okay. You will see that your deductible in this Medicare Advantage plan is $100. And your annual out-of-pocket max is $1,100. Okay. So that's going to be $1,000 plus your $100 deductible. What you're going to see, though, is that the primary care visits are going to have a copay of $20. Same thing with specialty visits. And ER visits are covered with a $120 copay. And the coinsurance in this first plan is 10%. That means if you were to go into the hospital, again, let's use worst case scenario. If you were to go into the hospital and need to be there for 3 weeks due to a medical condition, you're going to pay 10%, but the most that you can pay in any 1 year is $1,100. So again, if let's say on January 2nd, you had to go into the hospital, you were in the hospital from January 2nd to the end of January, you're going to likely pay $1,100 for that hospital stay. Okay, your deductible plus 10% up to $1,000. And then your out-of-pocket costs are done for the entire year. In fact, you won't even pay these copays anymore. The only thing that you would continue to pay are your prescription drug copays. But otherwise, anything else for that entire year is going to be 100% covered for medical. Now, if you and your spouse are both covered, these benefits are per individual. So let's say if you went into the hospital in that situation that we just explained, your spouse didn't, this is what you would be responsible for paying. And then let's say your spouse went into the hospital later in the year, they would have the same type of cost sharing arrangement. Now, if you move to the next plan, the other Medicare Advantage plan has a $250 deductible. But again, the out-of-pocket max is the same. The other difference here is that the coinsurance is 20%. So in effect, you're going to get to that out-of-pocket max a little bit faster. And the prescription drug copays are higher. And again, you will be mapped to one of these plans based on which design most closely mimics your current benefits. And with that, that is the kind of the layout of the benefits for January 1st for retirees, both pre-Medicare and Medicare. So with that, the kind of the formal presentation is done here, and we're happy to answer questions.
Hey, Jonathan, thank you very much. Just some information before we do start taking questions. All of these handouts that were presented today on the screen will be on our retiree VIBA website on the Board of Commissioners page. A video recording of this meeting will also be linked on this page. As we go through our questions, there may be a question that we're not able to answer. We don't want to just kind of blow smoke. We want to actually get you the right answer. So we will take that question down, and any of those questions we are not able to answer today, we will post on that same page with the full answer for you. Also, as we went through those plan designs, those mapping and plan designs are all available on that web page. So that our question session doesn't get too clunky, for those of you who are on the phone only, not with video, you can do *9 to raise your hand, and our moderator, Star, will unmute you one by one so that we can get there. And for those of you who are Zooming and can see the screen here, if you click on the participants button at the bottom of the screen, that pulls up a white screen to the right of, kind of splits your screen here. There's a raise hand function under all of those names. And if you have a question, you can raise your hand so that we can get to you. So with that, we will start. So if anybody has any questions, let us know here. We can kick it off.
Yes, this is Jeff Seifert. Can you hear me?
Yep, Jeff, if you can just use your raise hand function. We've got a couple of people that raised before you, so.
Okay, so I see Becky. There isn't a last name Becky. You have your hand raised. If you want to unmute yourself.
Hi, this is Becky Mosley. My question is, how long is this plan good for? In another year, are we going to have to renegotiate all over again? And what's going to protect us from it going crazy?
Nothing.
Thanks, Becky. It's Jonathan. Are you there? You can kind of talk about length of plans.
Yeah. So these plans are good for the amount of time that they're in force. But specifically, if you look at like the Aetna Medicare Advantage plans, the rates that were quoted by Aetna for those plans are good for 2 years. So for 2021 and 2022. The truth is, what we've seen in the Medicare Advantage space is that costs tend not to increase very quickly, so that these types of plans are much more sustainable over time than non-Medicare based plans, like the prior arrangements that were in place with HAP and Blue Cross Blue Shield of Michigan.
But what is our protection so that going forward, this doesn't get more expensive for us? And that might be a question more for Josh than for you.
Yeah, I guess I don't have a firm answer for you on that. You know, the board is committed at least through the next fiscal year to stop all premium pays. for those people who currently pay a premium to help offset it a little bit where they can. But I think most of you have probably sat through our financial presentations where we've started this process with Plant Moran and through Nyhart, who is our actuary, that shows that if we stay status quo, that in 10 years or so, our annual cost for retiree health care is about $35 million. And that's just not sustainable as a county. So, I know in talking with all of the board members, they've committed to try to make this impact as little as possible on retirees. So, not knowing what's going to happen in 2 years, I can't and I don't think the board can make a firm commitment on what that will look like. But I'm just guessing the board will have to take that up.
Okay, just
Who's
one.
our next? Yep, go ahead.
Jonathan was talking about the Medicare being for 2 years. What about for the pre-Medicare? What's the lock-in for that?
The pre-Medicare, so the pre-Medicare plan is a self-insured plan. So there's really no lock-in. Just to kind of, I don't want to get too into the weeds, but a self-insured plan means the county is effectively serving as their own insurance company. And this was the case, by the way, the Blue Cross Blue Shield of Michigan plan that's currently in place is self-insured. So this isn't anything necessarily new in terms of financing for the county, but there's no lock-in per se. If you noticed in the pre-Medicare presentation, we spent a lot of time talking about different things that are meant to help control costs over time or drive, better care delivery. That's really how we're going to control costs over time, is more people that are using things like 98.6, more people that use the KISS program, more people that use Livongo. Those are things that generate cost controls for the county over time. So the more uptake and acceptance we get in those types of programs, the more sustainable the costs are going to be over time.
All right, thank you. Our next caller on the line, I feel like a radio show host here. 629-1832 is the one that is unmuted now. Is she or he muted themselves?
Yep, if you could
So
please.
*6 on the 629-1832 will unmute you. There you go.
Okay, this is Carolyn Cook calling, and I'm calling about the retirees that have Medicare. And you said there was a $1,100 a year deductible for catastrophic. What if it's not catastrophic? Like if you spent 1 day in the hospital and were released, are you responsible for $1,100?
It depends on what the cost of that hospital stay is. So if you were in the hospital for a day, and let's say the bill for that is $1,800, you'd be responsible for 10%. First of all, you'd be responsible for the first $100 for your deductible if you haven't satisfied that yet. And then you'd be responsible for 10% of the remaining balance. So if it's $1,800, you're going to pay the first $100, and then you're going to pay 10% of the remainder, which would be of the remaining $1,700. So you're going to pay a total of $270 for that one night. And that $270 would apply to your annual max of $1,100. Okay.
All right. What if you were in ER and you went home? Now you have that $120 bill, but within a 24-hour period, you had to go back into the hospital because of something. Are you still responsible for that ER bill, even though you had to go back into the hospital for the same issue?
Yeah, the only time that the ER copay is going to be waived is in the event that you're admitted into the hospital as a result of that ER visit.
Is that immediate, or is that within a time frame?
Yeah, It all depends on how the medical provider bills it. Okay. If it's billed in such a way that the admission is related to the ER visit, then then the ER copay will be waived and you would only be responsible for the cost sharing associated with the inpatient admission to the hospital. Okay. It's not billed that way. Again, we're getting into the weeds. This all has to do with kind of the paperwork stuff that the doctor's office or the ER and the hospital are doing behind the scenes.
All right. I have one more question. If so many providers take this plan of Aetna Medicare, why is it when I get on the site and I put in 2 PCPs and 2 specialists and I get one that's covered under this plan? And my question is, if they're all a Medicare provider, how come they're not on your site? If they take Medicare, they're supposed to take this Aetna Medicare. Why is it when I go to the site, they say, no, these 3 doctors are not covered?
Yeah, it's because provider searches in the Medicare space don't necessarily work the same way that like it would if you were working with a traditional PPO, like in a pre-Medicare space. What the website is showing you is the folks that are in the Aetna portion of the network, but it's not showing you the people that are, or the providers that simply accept Medicare. Okay? And remember, we didn't show you in and out of network benefits because there are no difference between in and out of network benefits. If you're in the Aetna Medicare Advantage plan and you're going to see a provider that accepts Medicare, regardless of whether they're in the Aetna network, your benefits are the same.
If I call that provider and he says, oh, I do not take Aetna Medicare Advantage plan, do I argue with him saying that, well, you're a Medicare provider?
Yeah. Well, in that case, I would recommend reaching out to the Aetna folks, calling Aetna, the Aetna Medicare Advantage folks, and asking them to contact the doctor on their behalf. We heard about these issues more often a number of years ago when Medicare Advantage plans were just picking up popularity. We do not run into those types of issues nearly as frequently anymore because the provider community is much more familiar with Medicare Advantage plans.
And then if that is the case, once you just said that, I've been doing some research and they said that this Aetna Medicare plan is only taken in 8 counties here in Michigan, while if you have the Medicare Plus Blue plan, they go into 29 counties plus extras. It makes me tend to wonder why providers will not take this Aetna Medicare plan. Why?
The counties I believe that you're referencing are where these plans are sold, not where the providers are that accept the benefit. So Medicare Advantage plans are governed and regulated by Medicare. Okay, so the insurance companies that sell the Medicare Advantage plans oftentimes do not work through the credentialing process to sell the plans in every county. That doesn't mean that there aren't providers in those counties that accept the plan. It just means they're not selling the plans in those counties. Furthermore, it's very likely that what you're looking at is an individual Medicare Advantage plan. The Medicare Advantage plan that's going to be offered through the county is a group Medicare Advantage plan.
No, I understand that.
Yep.
Okay,
All right.
Thank you. If you have any further questions, just go ahead and raise your hand again and we'll get you in the queue. Next caller is 5690281. 5690281. It's kind of like radio and bingo all at the same time here. You are muted, so *6 to unmute yourself.
Okay.
There you go.
Right. Can you hear me?
I can hear you. Go ahead. What's your question?
Okay. Is there any difference in the coverage between whether the provider is in Michigan or out of Michigan?
No. There's no difference. Was that the only part of your question?
I think they may have muted
Might need
themselves.
to
Okay.
unmute again, sir. I'm sorry. Star 6 to unmute.
Star 6 to unmute if you had anything. No? All right, our next caller, 989-362-6363. You're next in line here. Go ahead and star 6 to unmute yourself. 989-362-6363.
I think you're unmuted.
No?
Oh, no.
All right, we'll go to our next caller, 618-3631. You're muted. You've muted yourself, so star 6 to unmute yourself. 618-3631. No, our next caller then is Bob Agel, I believe. Can we unmute Bob? Go ahead, Bob.
I take it none of this has anything to do with vision or dental coverage?
No changes to vision or dental.
Super. Thank you.
You're welcome. Thank you for the question. Next caller, Jeff Seifert.
Yes, I have
Go ahead, Jeff.
about three questions. The Livongo, is that for diabetes types 1 and 2?
It's predominantly for type 2 diabetics. They do have a program for type 1 diabetics as well.
Okay. Second question, under Medicare for retirees, can you explain passive? I assume that's versus active.
Yes. An active Medicare Advantage plan or an active network with a Medicare Advantage plan, all that means is that there is a benefit differential between in-network and out-of-network providers. Passive means the network application of the benefits is passive, meaning there is no difference between in and out of network benefits. That's the difference between an active plan and a passive plan.
I would urge HR to include that definition in any literature going out to the retirees. Next question. When you say maximum payable per year, are you talking a calendar year for everybody, or is this year different for everybody?
That's a really, really good question, Jeff. It's a calendar year basis. So all Medicare Advantage plans are going to be run on a calendar year basis. The pre-Medicare plans are also going to be run on a calendar year basis. And what that means is that when you transition from, there isn't going to be any issue when you're transitioning, from one to the other with respect to difference in plan years.
Okay. Possibly the last question. In reference to your slides, you talk about these contact sections like quantum. Mm-hmm. Yet there was no information provided on how to contact them. I'm going to assume that all of that is going to come out to the retirees eventually with emails and phone numbers, et cetera?
Correct. The quantum contact information will also be on your card. And it will be featured prominently on the ID card that you receive. In fact, for the pre-Medicare folks, what you're going to see on your ID card is that Quantum or MyQ Health is going to be featured just as prominently as the name Meritain, the administrator of the plan, because we want retirees to get into the habit of making Quantum your first call to get that specialized assistance.
Well, lastly, I want to thank you, Jonathan, for being patient for us retirees. Thank you.
You're very welcome.
Thank you, Jeff. Our next caller is Lisa. Thank you.
Hey, I'm assuming you can hear me now?
We can. Thanks, Lisa. Go ahead. What's your question?
My question is, I keep hearing the 1% to 3% increase from what we currently pay. I'm in the HAP plan where I pay nothing. So the way I see it is 1% to 3% of nothing is still nothing. Is that correct?
Jonathan, you're muted.
The 1 to 3% is an actuarial value. So it's not 1% more than what you're paying right now. It's a 1 to 3% in terms of the plan design value versus what you have right now. So that's the difference.
So if I pay nothing now, I'll pay nothing after January 1st?
No, you would pay if you're in a plan where you're paying nothing, you're likely going to be mapped to the $100 deductible plan that we talked about. Kind of is are you in the are you a pre-Medicare or Medicare retiree?
I'm pre-Medicare. My husband is post-Medicare.
Okay, so you would likely transition over to the Meritain plan that has the $100 deductible, and your husband would map over to the Aetna Medicare Advantage plan with a $100 deductible and the lower copay, the lower prescription drug copays.
Okay, can I ask Mark Young a question?
He is here. Are you answering questions today, Commissioner? Yep. Just make sure your microphone's on.
Mark, are you ready?
Go ahead.
All right, my question is, how is this equivalent to what I had when I retired based on our collective bargaining agreement? It says that it has to be equivalent plan. And on my plan, I have no copays for doctor visits or anything else. How is this equivalent? And that's my question.
So I would just say before the commissioner speaks that it was a collective rather than just going after one commissioner. I guess it was a collective decision by the board, and that may be better addressed to the full board. But Commissioner Young is my boss, so I'm going to do what he tells me to do if he wants to answer it. The purpose of this town hall was kind of talk about what benefits are going to be offered in January for retirees. I understand what your question is, and if Commissioner Young wants to speak at this time, then that's his right to do that. But I think that we want to try to make sure that as we move forward in this process today, in this particular Zoom meeting, that we kind of focus on what those benefits are going to be January 1 versus why the change was made, or the legality of making the change, which was really a decision made by the board. So with that.
Yeah, can you hear me, Lisa?
Yes.
Okay. Yeah, I don't believe that it is the same as what your collective bargaining agreement had. It is being changed. It is being changed by a decision of the board, which I have fought this decision, and I have literally been fighting this decision since I got on the board in 2013. It just took this long for there to be enough like-minded people to look at trying to change this policy. I do know a couple of the commissioners are looking at it as a way of trying to minimize the amount of harm that is part of the reason why they may have supported it. But again, I am like you and many of the other retirees. I do not agree with this. And it's something that I feels like is being crammed down our throats, being crammed down the throats of retirees. But so that's my position on it, and I'm not going to change.
Right.
So.
I apologize for putting you on the spot, but I was told at the beginning that you were the only commissioner there, so that's why I asked for you.
Well, and I've been on the spot on this particular issue, like I said, from day one of me being on the board. So I've been vocal behind the scenes for several years on it. Whenever anybody tried to talk to do it, we were able to hold it in check up until the Supreme Court decision came out. Basically, that kind of took away some of the ability we have to control what direction that goes. So.
All right. Well, thank you. That's the end of my question.
Thank you, Lisa.
Thank you, Lisa. Our next question would be from Lily Wyatt. Lily, are you there? You're muted if you're there.
I'm unmuted. Yeah.
I
Thank
hear
you, Lisa and Commissioner Young, for answering the question that I had. And I'm in Nevada, so I won't have any problems with that in Nevada, because in Nevada now they're trying to get you to go with a Medicare Advantage plan that they're offering here. So I don't need to do that, right?
No, you don't need to do that. In
Okay.
fact, that it's very common for insurance salespeople to contact Medicare participants. You do not want to, if you're receiving benefits through the county, you do not want to enroll in any other Medicare plans outside of what the county is offering. This is because the Medicare space is, again, federally regulated. If you enroll in a Medicare plan outside of what the county is providing, it will prevent the county from enrolling you in the Medicare plan that the county is providing. Okay? So it's very important that you only take the county's Medicare benefits and not enroll in another one.
Okay, thank you. That was my perception, and that's what I thought.
Yep.
The other question is, was answered by the dental and vision being covered. And so when I retired in 05, I always thought that I had the Cadillac of the programs, and I had Blue Cross Blue Shield as my secondary. So are we saying that Blue Cross Blue Shield is no longer participating in anything?
Correct. You will not receive any type of coverage as of 1/1/2021. You will not be receiving any coverage through Blue Cross Blue Shield of Michigan.
Okay, so we won't have secondary, just Medicare Advantage will be the only program that we have.
Yeah, and you know, one of the things we probably should have mentioned this, and probably just slipped our minds, or my mind, but for those of you that have Medicare, your base Medicare, your supplemental coverage that you're used to having with Blue Cross Blue Shield or possibly HAP,
Right.
it's all rolled into one plan. So you're only going to have to carry one ID card for your medical, and then you'll have a second card for your prescriptions. And this is specific to the Medicare folks. You will no longer have to carry both your Medicare card and a Blue Cross card and the prescription drug card. You only have to carry two of those going forward.
Okay. Thank you. One other question. My husband is, on my program. And so will he get the cards too? He's on Medicare and he'll get cards too. Okay.
Yep. The Medicare.
That'll replace our current Medicare cards, correct?
Yeah, correct. Yeah, in the Medicare space like this, everything really is at the individual level. So you'd both get your own cards.
Okay. Thank you so much.
Yeah.
Thank you for the questions, Lily. Sherry Cornett is next. Sherry? You're muted. Sherry, are you there? No Sherry? All right. Teresa Blaine? Sherry's here.
I'm here. Can you hear me?
We can hear you now, Sherry. Sorry about that.
No, this is Teresa Blaine.
Sorry, Teresa. Go ahead, Teresa. We'll come back to you, Sherry. I see you there. You're just muted, so you'll have to unmute yourself when we come back. Teresa, go ahead.
Okay, Teresa Blaine from Charlotte, North Carolina. And my question, the thing that's giving me the most anxiety is which prescription plan I'm going to be on. And people keep saying you'll be assigned, you'll be mapped, whatever. But when? Because right now is the time we're doing our flexible spending account. And it's really important to know how much. We're on a lot of prescriptions down here, and it's important to know how much they're going to go up. Are we going to go into the $20, $40 one or what?
Teresa, can you tell us what your prescription drug copays are right now?
Yeah, they're 5 and 10.
All right. Let me see. I believe you would be mapped to the 5/20/40.
Yeah.
But I'm going to check on that really quick. Bear with me for a second. Do you have while I'm looking this up, do you have any type of secondary question?
My secondary question was basically when will we be notified for sure? And also to let the Board of Commissioners know that I was not notified. I didn't receive any notification about that a decision had been made back in August until I received this little flyer. So I don't know, I'm concerned about getting notified because these things are important.
Sure, I can speak to the notification process. I think there's been 5 letters that we have mailed using the post office since this process began. Each of those letters does speak to a website that we have set up and dedicated to the VIBA/retiree healthcare, where we're posting a lot of this information. You know, as you can imagine, with so many retirees and they're spread out across the country, that, you know, we don't have email set up or email for all of the retirees. So we're trying to use every avenue possible to reach out and keep people informed about what's going on. If you got that letter, if you email me or Marie in our office, we'll make sure that you're on the email list so that you can get those notifications ASAP. With some issues with the post office right now, obviously there's been some delays in getting these letters into the hands of folks. But we'll get you on the email list so you're there. So you can email myself or Marie. I forget whose email address is on that
I have
letter.
viva@countygenesee.us.
Yep, perfect.
Just
Both Marie and I
email
get those.
there. Okay,
Yep,
thank
you can email there. And then Jonathan, did you have her new
Yeah.
plan?
Yeah, you would map to the plan with the $5 generics, $20 preferred brands, and $40 non-preferred brand.
Okay, that's what I was afraid of. Thank you.
You're welcome. Sherry, are you ready to go?
Yes, can you hear me?
We can. Yep. Go ahead. What's your question?
This is Sherry Thompson Cornett. I'm calling from Waco, Texas. And all of my questions have been answered, but the Livongo, my husband is a diabetic. And does Livongo also go for the Medicare, or is it just the pre-Medicare?
Good question. It's only the pre-Medicare population that will have access to Livongo. I do know that Aetna, the Medicare Advantage plan, does have some services related to helping diabetics manage their program. It's not the same exact program, but it would probably be worth it to reach out to them after the first of the year to get engaged.
I was just wondering if they help if they help with getting diabetic supplies.
You can get the diabetic supplies through the Medicare Advantage plan. Yeah, but I would my recommendation would be to contact Aetna really probably sometime in mid-December, once all of your information is housed with Aetna, because if you try and call before that, they won't know who you are.
Right.
Okay, but by the middle of December, they should have all of your information. You should be able to call and say, or really have your husband call and say, hey, I'm diabetic. What type of programs do you have to help with diabetic supplies, management, et cetera? And they can help you with that.
Okay. So then as far as prescription drug copays, I mean, right now I pay very minimum of anything. So I would assume that I would be on the lesser copay program, but I don't know that for a fact, but eventually we will, when we get our new information, it will tell us what our copays are going to be.
Yes.
So Jonathan, if I can just jump in real quick, Sherry, there on the website, they do have the mapping for the plans that include the prescription drug. If you don't know what plan you're under, if you want to email that VIBA email address, we can tell you what exact plan number you have, and you can compare it, side by side for you.
All right. I appreciate it. Thank you so much for all your help today.
Yeah. Hey,
Thank
Sherry
you.
Josh, Sherry brought up a recurring question in the chat, which is, Livongo, KISS, 98.6. Are those things that are going to be available to the Medicare population or only the pre-Medicare population? Those programs, the KISS, 98.6, Livongo, Quantum, those are all programs that are exclusive to the pre-Medicare population. And if the question is why, The truth of the matter is, in the Medicare space, things are a lot more heavily regulated because Medicare is a federal program. We don't have as much flexibility in the Medicare space that we do in the pre-Medicare space.
All right, our next person is Diana Menzing. I think I said the last name right.
Hello.
There she
I'm calling from Sumter, South Carolina. And I had a couple questions, though a couple of things have been answered. The dental coverage and the vision coverage. So those cards we will still carry separate, along with the Express Scripts card will be separate, and then our Medicare Advantage.
Correct.
Okay. And then on my Express Scripts, we pay only like, it doesn't matter the cost of how high it is. Like I have one that's $1,000 a month and I still only pay $2.
Yeah.
So I'm wondering what ours is going to jump up to.
It's very likely if you're only paying $2 right now that you're going to be going to the $2, $5 prescription drug. So the most that you would pay for a prescription is $5, as opposed to $2. So, but again, that's going to be dependent on the type of the drug. So it still could be $2. It may be $5, but the most it's going to be is $5.
Oh, okay. I was wondering because there's one that is a brand new one that they put me on for migraines, and it is over $1,000 a month, and I only pay $2. So I was wondering if that they don't have a generic for it or that.
Yeah.
Hey, Diana, if I can just jump in real quick, just same with anybody. If you have any questions on where you're being mapped to, my direct dial here at the county is 810-762-7762. It's a full house, 762-7762. And I can walk you through that and just, I get a lot of phone calls about healthcare right now, so just give me a minute, but I will get back with you and I can answer those specific questions about mapping, and I can give you the specifics as to where you're going on the prescription drug.
Okay, and which person am I speaking to right now? So when I call,
That's Josh. Josh. Yep.
Okay.
And if I can't answer you, I'll send you over to Anita at HR, and they can have the benefits person talk to you as well.
Okay, then one other quick question. On that letter that we just got, it says that you'll be able to take advantage of the many health and wellness benefits this new plan offers. We were wondering if that includes any gym benefits like membership at the Y or anything.
It does not. So the program does not have a gym membership benefit. That said, there is I believe there's a discount program through Aetna Medicare Advantage. So they do have some gyms that you can access at a discounted membership fee.
Okay.
Diana, you brought up a good question, though. I know you were asking specific to your own medication, but I think broadly speaking, it probably bears repeating. Because we're not changing the relationship of the vendor who's doing the prescription drugs, we're not necessarily changing what's covered. Okay. That said, I mentioned it before. The drug industry in general changes very, very frequently. So any type of changes of what's covered or what's not covered, those are standard changes that occur organically over time in the prescription drug world because of how the industry changes. Okay, but we are not changing. Like, we're not saying that the county's plan is no longer going to cover migraine medication. We're still going to cover migraine medication, but if the drug that you're taking right now that's $1,000 a month eventually goes on generic, at some point in time, the $1,000 version might not be covered. Only the generic version might be covered. Okay. So I just want to be very clear with that, because sometimes people will think that the county is making a change when in fact it's really just the drug industry that's changed, or there's a new drug out on the market, or something's gone generic and things like that. Okay.
Okay, thank you.
Thanks, Diana. Next person in line is Chet Coop. Mr. Coop?
Okay, can you hear me?
We can.
Okay, I just have 3 quick questions. The first is, what do you do for medical expenses that occur overseas? This happened to me back in 2013. My wife required emergency room treatment in the Netherlands, and Blue Cross Blue Shield at that time, we just got all the bills and sent it in, and they reimbursed it. But we travel a lot overseas, and specifically, how does that work? Or is that not covered at all?
Nope, it's covered the same exact way that it is right now. So in the event that there's an emergency, that you would receive care, as necessary. But I want to be clear that these plans only cover emergencies. So like if you were traveling overseas, I don't know, maybe you're going for like a month at a time, and you need to receive, a standard procedure. Those types of standard ongoing procedures are not covered when you're overseas. It's only emergencies that are covered.
So if you went in for an emergency thing, and let's say her situation required admission for surgery, it didn't happen that. So the emergency care would be covered, but not the related surgery?
If the surgery was related to the emergency, like the surgery was absolutely necessary to occur at that point because of an emergency, the surgery would absolutely be covered. And the way that you would handle that is exactly the way that you handled it with Blue Cross, which is you typically have to gather the receipts and such, and then you submit them through the insurance carrier to get reimbursed. And the reason you have to do that is because the foreign healthcare systems, they don't know how to bill our insurance companies. So usually that responsibility falls unfortunately, on the insured or the patient to request those reimbursements for those overseas emergencies.
Two quick questions and I'm done. You were talking, I'm a little confused in terms of services that they provide. I'm a retiree at Medicare Advantage. Who do we contact relevant for information assistance? Is it Quantum or is it North 44? What's the difference and who do we use for what?
Yeah, great question. So if for your Medicare Advantage going forward, you're going to want to contact the folks at Aetna. So there will be a number on the card, on your Medicare Advantage card, and they're the ones that you're going to want to contact that is actually Aetna. So the Quantum is only available to pre-Medicare individuals. You're going to want to contact Aetna directly for anything related to your medical. And then for prescription drugs, it would be Express Scripts. Again, the numbers for those companies are going to be on your ID cards.
But we won't be we won't have to contact North 44 anymore because they were like a patient advocate. We don't have to contact them anymore.
Correct.
Okay.
Right.
And my last question has to be, is relevant to maximum limits per category per calendar year. Are there limits for that? And specifically as an example would be, I'm aware of an individual that has take drugs on a monthly basis, which are quite expensive, and they are necessary to continue to live, and that adds up to quite a bit per year. So in any of these categories, regardless of that, are there limits per category that you can claim per year?
Yeah, so the place that you're going to see in the Medicare space, you're not going to find limits on prescription drugs. I shouldn't say that. There are limits, but there are limits that, on how many of the pills that you might be able to get at one time. So sometimes they only like to dispense X number of pills at a time because there's a danger associated with having too many in the house at the same time, that type of thing. But there isn't necessarily a limit like where you're going to run out, like they're not going to fill the script anymore because you filled it too often. The place where you will see a limit is on skilled nursing. So in the Medicare space, you can see that right kind of in the middle of the page there. If you're online, so you've got coverage up to 100 days per benefit period or per year for skilled nursing. That's really where the most common limitation is going to come up.
So for medications, then there is no dollar limit.
No, no, they're not going to say, hey, your script costs $8,000, so we're not going to cover it. That's not the way that works.
Okay. All right. Then obviously, when we get our mailer, our package that explains to us in detail what's applicable to us, at that point, then we would get in touch with Aetna for any questions or.
Yeah, I would strongly recommend that you not contact Aetna until the middle of December.
Okay.
To the point earlier, the folks at Aetna aren't going to know who you are until the county works through the process with us to get all of your names over to Aetna. Until they know that you have coverage come January 1st, they're not going to know who you are. So I would strongly recommend to wait until mid-December.
But our cards will be usable January 1st.
Absolutely.
Okay. Thank you.
Yep.
Thanks, Chet. Next caller is 869-1767. Looks like you've muted yourself, so that'd be a *6. 869-1767.
Hello.
Are you there?
Hello. Yes,
Hi.
I'm there. It's Karen.
Karen, go ahead.
I have several questions. I'm confused because I'm hearing that maximum out of pocket is $1,200 a year for pre-65. But then I saw in the packet of stuff that's $6,350. So is there any time we're going to reach the $6,350 then?
So Jonathan?
The only way that you're ever going to hit the 6,350 is if you have a lot of, and when I say a lot, I mean like a couple times a week worth of office visit copays and prescription drugs, because the out-of-pocket or the co-insurance maximum, the thing that protects you kind of from those catastrophic events, is $750. If you add on the deductible, whether it be $100 or $250, it would take a lot of $20 copays to make up the difference to get you up to $6,350. It's very, very unlikely that you're going to hit that number.
And then once we hit our maximum of the 1,200 or whatever that was, do we still have to pay the 10% copays on MRIs, CAT scans, blood work, all that?
No, you're done. Nope.
Okay, no copays after you reach that max.
No co-insurance after you reach the max. You'll continue to pay like office visit copays and prescription drug copays. But again, if you had to have like another MRI, you would not pay the 10%. Correct.
Okay.
Yep.
All right. And then I'm hearing that we're staying with Express Scripts and we have a contract with them. When does that contract run out?
Well, there's a couple different contracts. It effectively runs out in about 2 years.
Okay. And then will we be switching over to the Aetna drug plan?
I don't want to commit one way or the other. There's a potential of that, but as of right now, the drug plan and the way that we're dealing with that is an effective arrangement. So as of right now, I would say no, but things change, the industry changes.
Okay. Okay. And then I've heard like for pre-65 people, we're going to have an Aetna card, but listening to you guys today, it sounds like it's going to be Meritain.
Yeah.
So what is the answer to that one?
Yeah. So the answer is yes. You're going to have a Meritain card, and on that card, you're going to see the MyQ Health, which is Quantum, but you're also going to see that the Aetna name is on there as well, because that's the network that's associated with your plan. Okay. Meritain is the administrator. They're the ones that are paying claims and managing eligibility. things like that. Aetna is your actual network of doctors and hospitals. So actually all three names are going to exist on the card.
So if I ask my doctor if he takes my insurance, what insurance am I telling him? Meritain or Aetna?
I would ask Aetna.
Aetna is what I'm going to ask my doctor if he takes.
Yeah, because that's the network. What the doctor is gonna be looking at is, do I participate in this network? And the network is Aetna.
Okay. And then when will we get our packet in the mail that explains everything that's covered and not covered?
It should arrive sometime in November.
Okay. And then my husband, he's going to be on Medicare. So am I right in thinking that he only needs A and B and the county's going to pick up dental, optical, and scripts?
Correct. In order to be on the Medicare Advantage plan, a person does need to be enrolled in Medicare Part B as in boy. The county's plan, the Medicare Advantage plan, effectively is Part C. So it's the supplemental coverage. It's your Part D, D as in dog or D as in drugs, is going to be through Express Scripts. And then the dental and the vision will remain as is.
Okay, so A and B is what he needs through Medicare. Everything
Correct.
else will be covered through the county.
Correct.
Okay.
Okay, and then I have one more question. Is there anything pertaining to, is it called a stopgap? This Aetna program?
I don't. I'm not sure what the definition of stopgap is. How are you defining that?
I was told that, say you have cancer and the insurance company says they're only going to pay $1 million towards your care. Once you've exceeded the $1 million, they're going to drop you and they will no longer cover you for health insurance.
Yep.
Is there some kind of program like that through this Aetna?
Yeah. So those types of limits are prohibited now. Those are called lifetime limits, and those are effectively legal now under the Affordable Care Act. So those limits do not apply either to the pre-Medicare folks or the Medicare folks. So if you're, unfortunately, the person that gets one of those $1 million diagnoses, you're not on the hook of being taken off the plan just because you've exceeded $1 million or $2 million of healthcare expenses.
So that does not apply to these plans that we're talking about?
Nope. And they shouldn't apply really to any plan anymore.
Okay.
All right. Thank you for those questions.
Thank you.
Thank you. Next person, and we are running up about 15 minutes left on this particular call. Next person on the line is 869-0370. 869-0370. You did mute yourself, so a *6 and there you are.
Hello.
Hello. Go ahead. What's your question?
Yeah. I have a question about premiums. And, when I get my Social Security check, will I see a premium coming out of there for Medicare now, or where will that go? And I just would like to just say one thing right away, that I know it's very important to everybody to have all their questions asked, but we should consider that other people are waiting on the line. And those are a lot of things that will be answered by you guys on the phone or by paperwork. So, so talk to me about premiums with the new coverage and the Medicare.
So the premiums, that's going to be subject to, any premiums that you owe to the county. That's an issue associated with your collective bargaining agreement and how you participate. Medicare Part B, as in boy, does have a premium associated with it when you enroll. That is something that you would have to pay regardless of whether these benefits were changing or not. And that premium is income based, so it's on a sliding scale depending on whether or not you still have income coming in, in retirement. So That
Okay,
would be
all right.
that would be your Medicare Part B as in boy premium.
Okay, and my situation is a little bit different. I worked out of surface water management, and it was SEIU, and I got shuffled into another union, of which I think it was an ASME union, and I've called Human Resources, and I've not received a call back on exactly what union I'm in, what local. I'm wondering is there anybody else I could call to find that information out?
Sure. So I gave my phone number. This is Josh. I gave my phone number, my direct dial number. It's 762-7762. If you leave your name and information, I'll get with Anita and make sure that that you get a return phone call for sure.
I appreciate it. Thank you for your time.
Yep, not a problem. Thanks for the questions. We got, looks like 4 more people that are on the line. We'll get through those 4 questions. Remember, there are 2 other events tonight at 6, tomorrow at 2. So if you didn't get to your question or you have a new question that you think of, you can log into those meetings as well. Those are unique logins. That question was online. Those are unique logins. So if you want to participate via Zoom versus a phone call, you'll need to get that unique login. So just like you did for today. Mike's iPad, you're next. Mike's iPad. If your name is Mike and you're using an iPad.
Yeah, this is Mike Wilson. Can you hear me?
Hey, Mike, go ahead. Yeah.
Okay, I'm currently using Livongo and I'm post-Medicare. That means I'll have to quit using it, right? After January 1st?
Correct. Yeah, it's the program isn't going to be offered for Medicare primary individuals.
Okay, is it going to be up to me to find new testing equipment then, or what?
Yeah, you would want to contact Aetna to work out the transition there in terms of they're going to be able to help you find where you can get the supplies. Like I said, they may also have a recommendation on getting you into a similar program.
Okay.
To help you manage your diabetes. Okay.
All right. I've got one other question, and it involves services provided versus what the insurance company thinks they're worth, and the co-insurance payments that you make. Are the co-insurance payments based on what the provider values them at, or what the insurance company values them at?
It's based on what the insurance company reimburses or approves for reimbursement to the provider. So remember, in the Medicare space, Medicare reimbursements are effectively governed by federal government. So if the federal government says this medical procedure should be reimbursed at $1,000, you're going to pay 10% of $1,000. And if the medical provider billed $4,000 for that, you're not going to pay 10% of the $4,000. You're going to pay 10% of the $1,000 that's approved. Okay.
Thank you.
Yep.
Thank you, Mike. Next person, Kathleen Gibbs. Kathleen Gibbs. Are you there?
Morning.
Good morning. How are you? Got 2 for 1 on this call.
Yes, you do. I know I talked to Josh the other day about going to University of Michigan. I go for most of my health care there. And I want to make sure that there's not going to be a difficulty in the transition with this new program with the Medicare Advantage. And also I have several CAT scans coming up. And from what I understand, as long as U of M, accepts the Medicare, this should be all covered then?
Yes.
Okay.
Correct. Yeah, we have other people that have Aetna Medicare Advantage that use U of M without a problem.
Okay, thank you so much.
Yep, no problem.
Yep. Thanks for being with us today. Next caller is Mark Yagos. Did I say that right? Mark?
Vegas. Hello?
Go ahead. You're on the line. Go ahead, caller.
My question is, you've identified out-of-pocket costs in relationship to, say, for example, an MRI. But if I have a major surgical procedure, what would my out-of-pocket costs be related to that?
Yeah, if you're a little difficult to hear, but if I heard you right, you said, what would your out-of-pocket cost be if you had a medical surgery or a major medical procedure?
Correct.
And Mark, are you pre-Medicare or Medicare?
Pre-Medicare.
Okay, so if you're pre-Medicare, it's going to work very similar to that MRI.
Okay.
So in the event that, if it's a schedulable surgery and you use the KISS program, you wouldn't have any out-of-pocket costs at all. If you just run through the normal insurance, then chances are that medical procedure is going to apply to the deductible and the co-insurance. And then you would pay up to the co-insurance maximum.
Okay. So it wouldn't be 10%.
No, and see, that's the most confusing part, I think. Like when we say 10%, that's a co-insurance. And like, let's say you had a $20,000, or let's use a big number. Let's say you had a $50,000 medical procedure. You're not going to pay 10% of the $50,000 because you're going to hit your co-insurance max before you pay all the way up to 10% of $50,000.
Right.
Okay? So your co-insurance max is really going to cap your out-of-pocket for that major medical event.
Okay. All right. Okay, good. That's just what I needed to know.
Thank you, Mark.
Thank you.
Yep, next person is Gary's iPhone. Name's Gary, you're using an iPhone. Are you there? I see you're unmuted, Gary. Can you hear us? Gary? He muted?
No, it looks like he's unmuted.
Yeah. Gary, are you there? *6 maybe? Yeah, Gary's iPhone, but okay. I'm sorry, Gary. We got one last Kiss Alive 2. Kiss Alive 2.
Yeah, can you hear me?
We can. Go ahead, Kiss Alive.
Okay, I got, one real question and maybe one statement. Statement is, this whole thing started against the advice of your own counsel, which said you couldn't do this because you were violating most of the collective bargaining agreements in the county. So that's my statement. Second, what is to prevent the copay or co-insurance next year from going from 10% to 30%, and the year after that 40%, and the year after that 60%, and the year after that 100%, where we end up paying all our own? Because it's obvious your word don't mean anything because you violated darn near every contract in Genesee County.
So I can speak to that a little bit. I mean, I hear what you're saying in terms of contract language. The board made a decision to move forward, and I'm not here to justify that one way or the other. I'm here to provide the information of what we're moving forward with. That's something that that each person individually has the right to come in and talk to their commissioner individually, or come here and talk to them as a group and let them know what you're thinking.
Yeah, we're doing it as a group.
That's fine.
We're seeking legal action, so.
Right. I understand that. In terms of what prevents them from saying it's 100% or 10% or 30%, I would think that as elected officials, that they probably aren't going to go to a point where you're going to pay 100% of your health insurance. It doesn't make sense politically for them. So I
don't think this makes sense politically either.
I understand what you're saying.
We were guaranteed for life that we would have the same benefit at the same cost of when we separate from employment. And moving to this plan is in direct violation of that language for most of the collective bargaining agreements in Genesee County.
Sure, I understand your position.
No answer?
I answered it. I understand your position. I understand your position.
Okay. That's as good as I'm going to get. Thank you.
You're welcome. Thank you for being on the call. We've got 5 minutes. We've got Carol Donahue, and then that'll be our last caller. Carol? You'll have to unmute yourself.
Yes,
there you go.
Yes, I'm calling from Florida. I've been a retiree for many years. I've had the same program for all those years. I'm a little concerned about when you stated that this is only guaranteed for 1 or 2 years. Are we going to be going through this again? And is this program primarily offered to municipalities and our government government issues, or is it individuals, or how does it? What is popularity of this program?
And on the Medicare Advantage side, the popularity is it's not necessarily isolated to municipalities or private employers. I will tell you, typically municipalities are more frequently have retirees to cover. So you'll see Medicare Advantage programs more often with public employers just because they have retirees, whereas a lot of private employers don't. Medicare Advantage, though, is also extremely popular in the individual market. Okay, so it's both an employer solution, but it's also an individual solution. You'll tend to see a lot of, if you're watching a lot of network television this time of year, you'll start to see a lot of commercials for Medicare Advantage plans because we'll be going into the Medicare open enrollment season. Those are commercials for individual Medicare Advantage programs. But yeah, so there's popularity of these programs both at the employer and individual level.
But again, is this the 1 or 2 year program, and then we have to go through this again, or?
No, the intent here is not to kind of upset the apple cart every 2 years. What the county did was when we were looking at this, one of our directives was to try and create something that with some sustainability, understanding that change is difficult and that we don't want to do this all the time. So again, we aren't going to make any declarative statements that nothing else will ever change, but at the same time, the intent here is to have this be a sustainable solution for multiple years, not just 2.
Thank you.
Thank you, Carol. I see Gary's iPhone is back. Can you hear us, Gary? Gary.
Yes, I can, but I'm pressing star. There you are.
There you go. Go ahead, Gary. You're our last caller.
There he is.
Sorry about that. Trying to teach them all a new trick. Hey, I have a question. I'm a GM retiree. My wife's a county retiree. And we were told at one time that we could not have coordinated benefits.
Gary, you're really gargled up. Is there a way you can maybe speak more directly into the phone?
Yes. Can you hear me?
Yes.
Okay. I'm a GM retiree. My wife's a county retiree. Years ago, we were told that we could not use my Blue Cross Blue Shield coordinated benefit with the county insurance. Is that policy now changed since they're changing the promise of a lifetime of this Blue Cross Blue Shield through the county?
So in terms of coordination, I can tell you one thing for certain, that on the Medicare side, once you're in a Medicare Advantage plan, there is no coordination. And that's because you can only have one Medicare plan. Enrolling in multiple Medicare plans, and by the way, that's not a county thing, that's a Medicare thing. You're only allowed to be in one Medicare plan. With respect to the coordination, pre-Medicare, Josh or Anita, I'd let you speak to whether or not there's going to be allowances for dual coverage on the pre-Medicare side, or if that's a county rule.
I'll let Anita speak to that.
No, there's no dual coverage for pre-Medicare.
Why?
That was something that was bargained for in the bargaining units contracts many, many years ago before my time. I think it was just a cost savings issue. Either you choose the county insurance or you go on a maybe a spouse's insurance, and then you get the opt-out payment of the county for not taking the county insurance. But I think that was back in maybe 81, I want to say.
Okay, but there's no cost to the county for individuals exercising their right to a benefit that was afforded either their husband or their wife. So why would the county prevent that now?
Because,
So I think that, Gary, I think that's a good point, and that's something that we can talk with commissioners about. I mean, Anita or I don't have the power to make that decision. I understand what you're saying, that if you have insurance available through a spouse, that you would like to take advantage of that in an effort to maybe reduce some of the out-of-pocket expense for you. So that's something that we can talk with commissioners about, and then they can make that decision as to whether or not they want to move forward with something like that or not.
Yeah, I guess, you know, if it was bargained in 1981, additionally, what has happened now was bargained previous to an employee retiring. So it sounds like all contracts are off the board, and individuals should be able to do what they can do through their spouses to help them with the cost of health care.
Your point is well taken, Gary. Thank you. I see that we don't have any other questions. We're at our 2-hour limit here. Again, there's 2 other forums. If you think of something between now and 6 o'clock tonight or 2 o'clock tomorrow, go ahead and email Marie at that viba@co.genesee.mi.us email address, and she can get you the unique logins for those meetings. Otherwise, I gave out my personal contact information. If you have questions, don't hesitate to reach out to us. So thank you, everyone.
Thank you.